Good evening and a warm welcome to our Real Cath Lab Complications with Expert Advice Series 2. And we are on the 23rd of July 2022 and it's a Saturday evening. So we have an array of very good speakers from our national forum and also international forum from Bangladesh. We also have a very good array of expert panels. So the topics for today, which are chosen, are obviously the most challenging ones in angioplasty scenario. One is on the CTOs, and of course, the other is the left main. So we'll start I'll start by introducing my expert panelists, and then we can start our presentation. So let me introduce Dr. Jimmy Reddy. He's a consultant cardiologist at Lycée Hospital, Cochin. And then Dr. Sushant Kumar Pathak, consultant interventional cardiologist from Department of Interventional Cardiology, Ford Hospital and Research Center, Patna, Bihar. We also have Dr. Deepak Davidson, who needs no introduction. He's a good friend of mine, and he's the Chief Interventional Cardiologist at Caritas Art Institute, Kottayam. We also have Dr. Farhana Ahmed, Assistant Professor, National Institute of Cardiovascular Diseases, Dhaka. And amongst us is Dr. Pradeep Kumar Karmakar, Associate Professor of Cardiology, also from National Institute of Cardiovascular Diseases and Hospital, Dhaka. Good friend, Dr. Mandar Mahbub Shah, Head of the Department, Tata Main Hospital, Consultant Interventional Cardiologist at Apollo Multi-Speciality Hospital is Dr. Uday Shankar. And my dear friend, Devashish Ghosh, Senior Consultant Interventional Cardiologist at Apollo Multi-Speciality Hospitals, Kolkata. So the introduction part of the speakers and the panelists are done with. Now I can invite Dr. Deepak Davidson to talk about the tools I have in my CTO box. It's going to be a very interesting presentation. And Dr. Deepak Davidson, of course, is a fantastic speaker, and he makes things so lucid. So we're looking forward to your lecture, Dr. Davidson. Over to you.
Sir, I'm extremely sorry, sir. I was not aware of this talk, sir. I was just asked to be part of the program as an expert panelist, sir. I think somebody else is supposed to speak.
Okay. So, all right. So, no, I have actually this thing in me. Okay. What we'll do is we'll go to our next speaker, Dr. Farhan Ahmed Shubhabrato. Is Dr. Ahmed with us?
Yes.
Okay, Dr. Ahmed, welcome, a warm welcome from Kolkata. So we will be hearing from you, challenging left main intervention. So over to you, Dr. Ahmed, for your presentation.
Thank you. Thank you for having me in Kolkata live and also for the opportunity. Am I audible? And is my slide visible?
Yes, you're audible and your slides are visible if you can maximize. Yeah, it looks good. Yeah.
Today I'm showing you the challenging left main PCI. We all know the left main disease is unique in terms of LM anatomy and disease morphology. When we deal with LM, we deal with 60 to 80% blood circulation of heart and often 100% blood circulation of heart. So any mishappening can lead to a life-threatening consequence and catastrophe. So proper planning, proper evaluation of the lesion, and procedural simplicity is a very important thing while we're dealing with left main disease. So my first case is Mr. S, 35 years aged gentleman, presented with chest pain on exertion for 1 year. Patient was diabetic, smoker. On admission, patient was hemodynamically stable, stroke negative, EKG within normal limit, but TMT is positive for provocable myocardial ischemia. And coronary angiogram finding is like that. There's a severe stenosis in left main ostium. Also, the left main ostium is very short. There is also disease in LAD ostium and LCX ostium is apparently clear. And right system, there is also stenosis or obstruction in proximal part. So whether it is a biosteal lesion, what is your comment for right system?
Davidson, your comments, please. Or Devashish, Ghosh.
Hello, am I audible?
Yes, you're audible.
Yes.
Yeah, looking at it, basically, I think the lesion is proximal in the RC as well as ostial. So for an intervention purpose, you will have to cover the ostium here. Though I can't be very definitive about the ostium in the right coronary, because on the right-hand shot, the ostium is absolutely the classical junction between the artery and the aorta seems reasonably open. So it's a proximal ostial lesion. So I would actually try to, if I have to stent, I have to cover that. The only thing, it might be worthwhile taking a shot after GTN or intracoronary nitrate, just to make sure there's no catheter-induced spasm. Doesn't seem to be, but it's worth probably taking a shot with some GTN.
Dr. Davidson, your comments?
Thank you. Exactly what we did in our last we give GTN 400, and this is the view after giving GTN. That was actually a spasm in the right coronary artery in proximal part. So we deal with left main ostial disease. We took JL 7 French catheter. We chose JL here because it is a less aggressive catheter and we could manipulate it during our stent implantation and pre-dilatation as well as post-dilatation. So we wear both LCX and LAD with our workhouse wear and keep the guide catheter a little bit disengaged, that is 1 to 2 millimeter away from the left main ostium, and pre-dilate the lesion with 1.5 into 12 millimeter balloon at 16 ATM. And then we did IVUS. IVUS shows left main ostium is MLE is only 2.7 with disease with more than 60% plaque burden. LM distal part luminal area is 4.9 and left main mid is 2.09. And there is LAD ostial disease and LCX minor plaque. So we choice here provisional stenting, of course, with covering the proximal part of the LAD and obviously covering the left main ostium. The stent size was 3 into 32 millimeter and we inflated at 12 ATM. We took multiple view, and again at that time we put another wear, that is a floating wear, into the aorta, so that anyhow we shouldn't miss the left main ostium. So we took multiple view and then deploy the stent covering the left main ostium. And here is the diagram about the position of the stent in the proximal left main, because if we are not very meticulous about it, we should, it is possible that we can do a geographical miss. And this is the view after stent deployment. And again, we did post dilatation with 4 into 8 millimeter balloon at very high pressure, 20 ATM. And this is the final result. And this is IVUS after left main PCI. And we gain our expected luminal area in left main with no stent under expansion. My second case is Mr. R, 45 years aged gentleman, presented with chest pain for 12 hours. Patient was diabetic, hypertensive, dyslipidemic, was smoker, and on admission, her pulse was 90 beats per minute, BP was reasonable, but tropi was elevated. So we're dealing with a case of non-STMI. Patient has ongoing chest pain, so we took the patient to Cath lab, and also patient have impending heart failure. Heart rate is very high. I think I have some problem. May I share screen again? I'd like to share my screen again, please.
Dr. Saranya, could you please tell us what is the age of the first patient?
It is only 35 years old.
35.
Sir, I leave the meeting and then I again join. I have some problem with my internet possibly.
So, Dr. Ghosh, Dr. Davidson, I think it was a classical example of that right ostial lesion turning to be normal after TTN injection.
Exactly.
But it didn't look so, though. It didn't look so in the first go. I mean, it was a good try, but I also believe that probably it was a lesion. What do you think, Dr. Davidson?
Yes, sir. Looking at the left system as well as right system and an young lady, probably I felt that it might be something like a Takaisu, but invariably I would have also started off with nitroglycerin injection.
Yes.
In retrospect, I even also felt that probably now since the IVS catheter was open, probably the RC also should have been evaluated just to see if there was disease. Yeah, no doubt it's definitely spasm and nothing needs to be done for that, just to evaluate that. And I felt that probably we need to go one step ahead and evaluate ESR and whether both the osteo being involved with no other disease of significant disease of the other vessels, probably one should also think in terms of other causes of coronary artery disease rather than just atherosclerotic.
Absolutely.
So sorry for
yes, Dr. Ahmed, yes, you're on again. Yeah. Yeah, we can hear you and see you also. Yeah, please.
Okay. My second case is a 45-year-old gentleman presented with chest pain for 12 hours. Patient was diabetic, hypertensive, dyslipidemic, smoker, and on admission, his hemodynamically stable, tropi was elevated. So we are dealing with a case of non-STMI. But patient has ongoing chest pain, so we took the patient to urgently to Cath lab. And patient have also impending heart failure. That his heart rate is very high, and a angiogram showing there is a tight lesion in the distal left main and also involving the LAD ostium and LCX ostium. So we are dealing with a case of bifurcated lesion, and obviously we have to plan double stent strategy for this case. Right system was normal. In our lab, we routinely practice nanocrash technique for bifurcation lesion, even in left main, and due to its procedural simplicity and its short procedural time. This is a review of a nanocrash bench test. What we usually do, the stent position in the side branch, once stent is positioned to the side branch, and one size smaller NC balloon is in the mid branch, stent deployment in the side branch, and then stent balloon, then the stent is crushed with the main branch balloon, then the stent balloon pulled out and did simultaneous balloon inflation, that is first case, and second stent deployment in the main branch, recrossing of the side branch with balloon, then final case. This is in short the nanocrash technique. What we did pre-dilatation, with 2.5 into 50 millimeter balloon. You see there is also the disease in the LM, and the LED also diffusely disease. OM and LED is also diffusely disease. So we predilate the OM lesion and also the LCX. Just a minute. Then we did predilatation of OM lesion also, and put a stent to OM. Then we stent the side branch, that is LCX, covering the ostium, that just 1 millimeter, keeping 1 millimeter stent to the LM. And then the NC balloon 3 into 50 millimeter was put across the left main and LED and did crash of the LCX stent. And then pulled the LCX balloon to the left main and did simultaneous balloon inflation. And then we stent the main branch with 3.5 into 48 millimeter stent, and with covering the left main ostium. Then we did port with 3.5 8 millimeter balloon at high pressure, then rewiring the side branch, that is LCX. Then again did second case. Unfortunately the picture is not here. And again did report with 4 into 8 millimeter balloon at high pressure. I am facing problem with my Microsoft.
And discuss the case if you wish to.
I only have 2 slides left.
Yeah, you can just speak it over. If you have a problem with the presentation, you can just tell it like you have done after that.
Just a minute. Let me check again. You can discuss, I think.
Okay. Dr. Ghosh, your comments, and then we'll go to Dr. Davidson.
I think the first case, let's take the first case, and I do think that you should investigate her for basically an aortic issues. But again, you had to do the lesion. Keeping it simple and a provisional strategy is fine. I always find that in a left main stem intervention, the challenge is the left LCX ostium. That is my reading always. Is the LCX ostium, which actually is the main issue, which gives us bad or good results. LMCA lesion stenting is fairly simple, and I absolutely agree that if you do not have a significant lesion and you have done IVUS very rightly, and you have demonstrated that there was minimal lesion in the LCX, a provisional stenting strategy would be all right. The only thing is, you said you used a 4 millimeter balloon in the left main stem for dilatation. I don't remember what the IVUS was. I do feel that though, unlike Western patients, we do not have, say, 5-6 millimeter left main stem, but I think I would be more comfortable in putting a 4.5.
Okay. we did in my second case, I was post procedural. Do you like to see that? This is our post procedural IVUS in my second case, and it was shown that the left main is 3.5 only, and there is no under expansion of the stent in left main. We did post pot with 4O balloon at high pressure.
That's great.
Okay,
Davidson, any comments?
Yes, sir. Yes, sir. Yes, sir. Dr. Farhana, very meticulously done regarding both the cases. The first one, the most important point that I liked is for the ostial left main, you started off with a Judkins catheter through the femoral approach, a 7 French guide catheter. And for a bifurcation lesion, you need to have a lot of push and pull. You started off with an EBU catheter through the femoral approach. So for every beginner, that's a that's a great learning point. Start off with a Judkins catheter when it's a fang ostial lesion, and the bifurcation, you need to have a good backup support. The second most important point that I had in your mind is you wanted to keep it very first case as well as the second case. The first one, you wired all possible vessels, the circumflex, LED, and you also had a third wire in the aortic root so that the guide catheter doesn't get pushed into. There are two reasons why you need to have a wire in the aortic root. One, you could always prevent the guide catheter from getting sucked into the vessel. You can precisely position it right at the ostium with 1 millimeter into the aorta. And second important reason is when you pull out your balloon from the stented segment, that is, you stent the vessel, and when you pull out the balloon, there is every chance that your guide catheter can go into the vessel and deform the proximal portion of the stent. So when you have a wire inside the aortic root, so the chances of the stent getting deformed by the aortic the guide catheter also could be significantly reduced. So that's something very interesting. Then you did it. It was a very simple way of tackling that. You had a wire in the circumflex. You decided that you wouldn't unnecessarily go ahead with a kissing balloon dilatation at the bifurcation, provided you get a good flow in the circumflex artery. And just one point, like what Ghosh sir has mentioned, in many situations, in our patients, we see at least 4.5 or 5 millimeter vessel. In your second case, you clearly showed that the post-procedure IVUS, the vessel size is 5 millimeter in size. In the first one, even I also felt that it was looking almost 4 millimeter in size. So one challenge that happens when you size the stent is when you have a 4.5 or a 5 millimeter stent and the 5 millimeter left main, and when your LED is only 3 millimeter, there comes the challenge. So you take a 3x33 stent, which comes all the way into the left main. Blowing it up to 4.5 or 5 would be challenging. So in those situations, even if the imaging says that the proximal LED is 3 millimeter, I would prefer to take a 3.5 millimeter stent and then deploy it at very low pressures, 10 atmospheres or so that I wouldn't injure the LED. And then a 3.5 millimeter stent can be blown up to 4.5 or so, because whatever be the stent that you take, stent platform, even if it's a science group or an onyx group, a 3 millimeter stent wouldn't go beyond 3.75 maximum. It could go up to 4. It wouldn't go beyond 4. So a 3.5 can go up to 4.5 or 5. So I usually keep this particular point in mind. The imaging says that LED is 3 or 3.25. I wouldn't mind going with a 3.5 and deploy it at very low pressure so that I don't dissect the distal segment. Just wanted to know the thoughts of Dr. Ghosh sir also, because sir has mentioned that in the first case also he would have gone in with a 4.5 millimeter balloon because already a 3 millimeter stent has been deployed. Do you have any concerns regarding going with a 4.5 balloon inside the 3 millimeter stent, sir?
Yes, I do. Only some of the stents will accommodate, and you need to really know the profiles of the stent when you're using that. So that's a planning which you need to do from before. And I would do exactly what you have suggested. I would rather go in with the 3.5 under deploy it in the distal segment, and then try to achieve a 4.5 in the left main stem. I think there are very few left main stems which are actually 4 and below. So 4.5 is right. So I think there are some stent platforms which claim that they can go up to 1.5 times the profound diameter. And there are certain stent, if you remember, the stent platforms of a 3 and a 3.5, the stent platforms are the same. It's only the balloon which are different. So there are certain, I will not go into the commercial naming of the stents. I'm sure we can get that information. So I think that is one way to think. There are certain stent platforms where the stent of a 3 and a 3.5 is no different. It's only the balloon which is different. The other thing, there are some stent platforms which give us at least a leeway of 1.5 millimeter expansion beyond the what has been, say 3 will go up to 4.5. So I would be more comfortable planning that ahead. But easiest way, what you have suggested is right. I would do a 3.5, under deploy it in the distal segment, and then basically because I have IVUS, I will be able to see more or less what I have done. But I would be more comfortable with a 4.5 in the main stem.
Thank you, Dr. Ghosh and Dr. Davidson.
In my next case, sir, in my second case, we did report with 4 into 8 millimeter balloon at very high pressure at 20 millimeters. So the stent already gained beyond 4.5.
Yeah, I think that is absolutely fine. That is how you deploy it. If you achieve 4.5, you will be more comfortable with any strategy. And I think it's a very well done case. The thoughts on the second case, just hello.
Yeah, Dr. Ghosh.
Yeah, the thought on the second case, it was a hemodynamically unstable patient, as you said, impending failure. I think before you take on such procedure, if you have the provision, you should have an anesthetic standby who would help you out to intubate the patient very fast should it be necessary. Yeah. So that's one thing. The other thing, you would also think of an intra-aortic balloon pump support. At least keep it handy if that is required. And these are things which you need to pre-plan before you take. It was a very much more higher risk procedure. The first one was, I think,
support is not available in our hospitals.
Okay.
That's why we.
Okay. Thank you so much, Dr. Ahmed, for this two fantastic presentation. If Dr. Pathak is ready, we'll go on to our next case of a left main bifurcation. Dr. Sushant Kumar Pathak, if you're ready for it.
Yes, sir.
Dr. Pathak, we can't see you. We can see your slides.
Just when it is visible, sir?
Yeah, the slides are visible and we can see you as well and hear you. Please carry on.
Starting with the case directly. 54-year-old male, non-diabetic and hypertensive, presented with rest angina for last 5 days. He was on GDMT for CCS for last 1 year. ECG was done, which shows ST depression in lead V1 to V6 chest leads. Echo was done, which shows normal LV function with grade 1 vascular dysfunction. Patient was taken to the Cath lab. Coronary angiogram was done, which shows distal left main disease, along with the LED having long segment diffuse disease with significant disease in the mid part, along with LCS with long segment diffuse disease. RCA had a minor plaque. Patient was given option for both CABG versus multi-vessel PCI. Patient refused the CABG and opted for the multi-vessel PCI. These are the angiogram showing a significant LED and LCX disease lesion along with left main distal lesion. We pre-planned a technique for this, either directly go for dedicated bifurcation. We choose the decay crust as a technique. We wire both the vessel along with the pre-dilation of the LCX lesion was done. Day stent of 3.5 in 38 mm was deployed from left main with minimal protrusion in the left main, just covering the LCX ostia. Actually, the plan was to do mini crush, followed by the crush was done. Again, the wire was recrossed into the LCX lesion, followed by the main first kissing. After the first kissing, we remove the wire from the LCX. And then another DES stent of 3.5 into 48 mm was implanted from left main to LED. Then we do the after that, after deployment of the stent, we do the post dilation of the LED stent, followed by the pot of the left main stent. First pot, followed by again we recross the wire into the from left main through the strut into LCX, followed by then was first kissing was done. Sorry. After the second kissing, the final pot was done with the 5 into 6 mm NC balloon. And this is the final shot, having TIMI3 flow in both the vessel with proper coverage of the LCX. The problem, of course, one problem is that we don't have IVUS in our Cath lab. We have to, if we plan the lesion, then we have to bring the Cath IVUS from outside, from Boston. So thus, in this case, as it was not a pre-planned case, suddenly the patient came. That's why we were not able to do the imaging in this case. If your permission permits, I can give show another case of bifurcation in left system, LED diagonal.
You can go ahead. It is a short one. Yeah.
Yeah. Just a minute, sir. A 45-year-old male patient who is non-diabetic, non-hypertensive, presented with ongoing chest pain for last 2 hours. ECG was done showing inferior wall MI. Patient was taken for primary PCI. The lesion was the culprit lesion was LCX. We fixed the LCX lesion. Along with the patient has a lesion, significant lesion in diagonal and LED. We of course the primary lesion was fixed. The LCX. After 2 days, we planned for stage PCI to LED diagonal bifurcation. We choose the mini cullet as a strategy. Wiring to both diagonal and was done, followed the pre-dilation of the both vessel. Then with days of 2.75 in 28 mm was taken. First into diagonal was with minimal protrusion into the main vessel LED. It was deployed. Then the wire from the diagonal was recrossed into the main vessel through the strut. Then the opening of the strut was done with the 1.5 mm pre-balloon. Then followedly, we deployed a DES of 2.7.5 into 15 mm was close to the strap. This was the deployment. Then with 3.6 mm NC balloon, and the other wire then was parked into diagonal branch. Then we do the kissing with 2.75 into 10 mm and 2.75 10 mm bus ball done, followed by the pot again with the previous balloon. This is the final angiogram. Showing TME3 flow in the both vessels. LCF strain was also fine. Just regarding coronary bifurcation, of course, it is a stenting considered as a complex procedure. Still, there is no consensus regarding about the strategy that most of fit most, because there is a dilemma again whether to do a dedicated bifurcation versus provisional. Most of the operator prefer provisional over dedicated unless required. In a SCA scenario. Thank you, sir.
Thank you. Thank you so much. Dr. Karmakar, if you can give your comments, please, firstly, and then we'll move on. Gobroto, is Dr. Karmakar with us? Dr. Mandar Shah, is he with us for expert comments? Okay, what we'll do is we'll move on to our next case by Dr. Jimmy George, and then we can have some questions taken. So over to you, Dr. George, for your presentation on topic of left hand bifurcation imaging assisted bolt from the blue. So let's hear exactly what happened. Over to you, Doctor.
Thank you, sir. Thank you. I would like to thank Abbott as well as the Calcutta chapter for giving an opportunity. Actually, I was thinking it's complication sessions, but I think beautiful bifurcation cases have always been shown by both the speakers, and I would be shy like presenting not that great case today. So my patient is an 85 years old female nun. She's a diabetic. She had presented with exertional chest discomfort for a few weeks, which was progressing to a rest angina for 1 week, with no significant ECG changes or wall motion abnormality and a fair LV function. So this was the angiogram, which was showing an ostial circumflex 90% stenosis with mild blocking over the ostial LAD, as well as the distal major OM free of disease. And if you see the cranial view also, the LAD seems to be a large vessel free of disease, and the right coronary with the marginal branches also free of disease. So basically, you got a patient with a Medina almost 001, or some blocking of the distal left main, or the proximal LAD, can call it 111 also, but definitely it's more in the 001 category. Shall we plan this patient with a LM circumflex stenting, or just keep the stent at the ostial circumflex? Or should we upfront go with a LM bifurcation? If so, a crush technique, or should it be a tap technique? Or can she be left with medical line of management? Definitely when a rest angina is there, I wouldn't suggest that. But ostial circumflex always is Achilles heel, which will come back. So that also is there. But you cannot just deny that, but you need to go ahead with the proper treatment. So she was planned for careful ostial circumflex stenting, which may differ with others. I also had some hesitancy going like that. We kept a balloon across LM-LAD and did a 275/13 ostial circumflex stenting after pre-dilatation and wiring both branches. This was the deployment of the stent, keeping apart the struts not crossing the ostial LAD or injuring the left main. And this was the result after that. A small kiss was also done so that if at all any injury or if at all any struts protruding into the LAD would have been tackled up. And what to do? Leave seems to be a decent result. Should we leave it over here? So this was that small kissing balloon dilatation to make it more perfect. So it seems to be a well-expanded stent. Carina seems to be free of disease. There's no slow flow. There's no symptoms, no STT changes. Shall we leave it here? Or does an imaging has any role in bifurcation? So definitely, we thought we'll go ahead with an OCT and rule out our LAD and left main is free of disease. Sorry for this, not that clear picture, but there's some calcification in the mid LAD. And as you reach the co-registered where the circumflex wire comes out and roomy LM. But if you see over there, the area lumen area is around 4.58 at the ostial LAD to the distal LM, as well as some dissected block seen at the distal left main. Now the confusion was, now imaging has slightly made it worse, but we had cases where 1/4 of the quadrant of dissected block left alone, which supposed to be left alone, but came back with LM occlusions or near total occlusion. So that was a difficult scenario, decision making. We thought we'll better crush it properly, recross it, kiss it, and plan an LM-LAD stenting. That was a strategy planned. So the recrossing, the crushing was done, and the left main LAD was stented with a 3/5/38 design stent, which was deployed around. That was the deployment of the LM-LAD stent. And a pot with a 4x8 balloon was done. And that was the result. So thought of kissing it, give a final kissing balloon dilatation. The wire was recrossed across the distal struts. And we took a shot, and if you can see, there's something hanging out at the proximal part of the circumflex. And if you see the wire also seems to be either out of the vessel or in a small branch. Have we injured the ostium? Have we injured the left main or the just the circumflex? So there is some staining over there. Is it a dissection? Or is it a perforation? Or is it because of the wire which has made a penetration anyway through the struts or maybe through the vessel just after the stent? So carefully the wire was removed, and without giving much shoots, anticradally, slowly the wire was passed towards the distal OM. You can still see there seems to be some staining still left out. There was some minimal mild effusion which did not progress. Fortunately, patient was stable. We have the guide, the wires intact with a stable patient. So at this stage, we thought we'll image from the circumflex to the LM and see what exactly it is. So this is showed co-registered from the circumflex where the first stent was deployed. And that is this LAD ostium, where this ostial LAD wire comes, and this is the left main. So once again, you can see that is the distal circumflex. There seems to be a small dissection over there, but less than 1/4 and the proximal circumflex, and now the LAD wire coming up. So the lumen area and expansion that at all the distal circumflex, the proximal circumflex at the carina, as well as the left main seems to be intact, and only the distal circumflex stent seems to have a small dissection, nothing else obviously visible. So again, the carina was recessed because of the OCT catheter passing through all these things would have again meant a hell of the carinal change. So again, separate dilatation followed by a final kissing balloon dilatation. And fortunately, this time, no significant staining noticed rather than a bit of negative in the distal circumflex. Sorry. So that was a final part done with a 4-8 balloon. On conclusion, I would say ostial circumflex is always an Achilles heel, and that is something which we like to neglect or not to touch and leave it. Almost 50% chances of restenosis. Imaging definitely adds to any complex PCI, especially in bifurcation lesions. Complications can always arise even in the last shoot itself. So always be aware of that. And imaging always reinforces for better management of complications too. Thank you.
Thank you for your excellent presentation, Dr. Jimmy. So may I start with probably Dr. Davidson to talk a few things about this case?
Yes, sir. Jimmy, wonderfully done. As you mentioned, it's always a challenge to, regarding decision making. How exactly should we be positioning the stent? Should it be right at the ostium, or should we come way back into the left main? So, based on this example and whatever we had over in period of many years, I presently at this point of time, when I have such sort of lesion with no significant plaque in the left main bifurcation or LAD, still I would prefer going from the left main into the circumflex artery. Certainly, I would do imaging. I would want to see the circumflex size of the circumflex vessel so that I can decide on the stent sizing, and I would also want to see the size of the left main so that the expansion limits could be kept in mind. So I would certainly decide on based on your experience. I hope next time when you see a case like this, you would also preferably go from the left main to the circumflex. So there are situations wherein we tend to feel that we'll be precisely able to position right at the ostium. Only challenge is we tend to undersize the stent because we are always apprehensive whether if the stent size is bigger, we might dissect the left main or the LAD. So we tend to undersize. But then when we have a stent that goes from the left main into LAD, such a concern is never there. So we can go ahead straight away, deploy a big stent, post dilate it right at the till the carina and get away with that. And second interesting thing is regarding that that hematoma, whatever stain that was identified over there. And based on imaging, we understood that you didn't go ahead with a second stent beyond the circumflex first stent that was deployed there. And in retrospect, even I also, I felt that based on that particular OCT images, I felt that it was more of a hematoma, which is actually contained inside the stented segment. I've encountered this sort of staining inside the stented segment. In retrospect, I found out that it was a balloon rupture during post-dilatation. During post-dilatation of the stented segment, a pinhole rupture can go into the perforate, into the media, or even into the adventitia, producing these sort of hematomas. And when we do an OCT imaging, we would see that many times beyond the stented segment, nothing is there. There is no dissection beyond the stented segment, but we are almost angiographically sure, as well as the imaging also made us understand that inside the stented segment there was an intramural hematoma there. So it's hard to understand what exactly was the reason for that. Probably high pressure post dilatation would have led to that sort of staining over there.
Yes, sir. That is like I would also prefer always going from LM circumflex stenting, but somehow like it looked like a very LM LAD seems to be very, very much almost disease free. That's 85 years old female with almost free of disease other than the ostial circumflex. I didn't want to injure that area out, but that was my mistake. The other one, like hematoma, was kept in mind. Anyway, only thing is like after the LM LAD stenting and everything, nothing was passed out towards the circumflex. Only when the wire
was just the wire.
The staining came out. So whether the wire had went out of the vessel to some small vessel and cause some injury. That was something which I was thinking of, but I don't know, even the OCT also, but most probably it could be a hematoma only out in which would I come, because the main thing was the Karina was injured, or what I was thinking of, because kissing balloon dilatation was done almost twice or thrice anyway. So that also was a problem that that need to be tackled with a covered stent or anything. Then it's a hell of a thing anyway. So that was the issue.
Dr. Davidson, for the benefit of the viewers, what kind of imaging modality would you actually suggest maybe in these kind of situations, particularly when you are dealing with a case where there's a probability of a hematoma? Jimmy, you can also tell it if you want to.
So given an opportunity, I would, if I feel that it was a significant left main dissection, I would start off with IVUS imaging, so that the hydraulic pressure that we exert during injection for the clearance of blood, that can further lead on to more of dissection, that can close down the vessel also. But then in this particular situation, we are truly in doubt. We are really not aware what exactly is happening there. So that sort of situation, definitely an IVUS would not be superior to an OCT imaging. OCT would definitely fare better, because with an IVUS we wouldn't have got these sort of information, because based on OCT, Jimmy was very sure that distally he doesn't have to go ahead and deploy a second stent, because I've also had situations like that. Probably if I have time towards the end of the session, I can share that also, wherein I've done IVUS because there was a stain in the left main. No information could be achieved with the help of IVUS, went ahead with OCT, clearly understood that what is happening there, and went ahead manage that particular situation. So certainly, sir, I would also prefer using an OCT in this sort of distal dissections when we are suspecting distal dissections. But when it's an ostial or a proximal left main bifurcation dissection, I would go in for an IVUS image.
I think you're absolutely right in the thinking process, which is very, very important. That, I mean, the algorithm that why should you do the IVUS first instead of the OCT, particularly when you're dealing with a lesion or a problem in the left main, distal left main or ostial LCX. I think that should be very clear in the mind of the operator about the hydraulic pressure and creating more dissection with the injection of with the OCT. I think if we do the process correctly, I think the outcome definitely would be better. And I'm sure that our listeners and viewers can understand the magnitude of the problem. The problem is not the complication, but the problem is how you actually approach the complication to come to a logical conclusion. So, Dr. Ghosh, any comments from you?
No, I think it's all right. You learn more for cases which have not gone right. I think that is the bottom line. I think that was great, and I would agree that you can rarely cover the ostium perfectly. You have to come back to the left main. But what would you do to Dr. George and Dr. Davidson? Suppose you have taken a stent, covered the ostium, and have come back into the left main stent. Would you do a kissing into the just a balloon kissing into the LAD, or would you stent it?
So regarding my option, certainly I wouldn't go ahead with a second stent. Even I think you also wouldn't go with a second stent. Jimmy also wouldn't go with a second stent, because he had some sort of plaque rupture or a dissection in the left main. He had to go with a second stent. Most of us, we wouldn't definitely go with a second stent. We would all stop with a short kiss, with a low pressure kiss at the bifurcation.
Yeah, I think I would agree with that. That's exactly. Say, suppose it went right, and you had a little bit of the stent back in, as both of you suggested, that on hind sort, you would actually extend the stent into the left main stem. That's right. You would recross and probably do some amount of opening into the LAD with the kissing. Now, whether you would use a second stent, the only thing I would do that if there is, I would image it, and if there is any hint of any injury, significant injury, obviously then the stent becomes mandatory.
Yeah, I think we all agree that left main bifurcation and left main stenting, the kiss of the balloon is one thing, and I think the kiss of a keep it simple is also another kind of a kiss which we should all follow. So let's move on to our next presenter. Thank you, Dr. Jimmy, for your excellent presentation. We move on to our next presenter, Dr. Uday Shankar Das, and he'll be talking something about the complications in the cath lab, which you are always having, and which we'd love to hear exactly what happened with it. Over to you, Dr. Das.
Just a minute. Let me share the PPT, please.
Dr. Davidson, if you have something for us, you can present in the end. We'd love to hear you.
Certainly, sir. Sir,
Yeah,
I'm searching
okay.
for that.
Okay,
I got it. I'll
So
certainly present. Certainly,
yes.
I'll present it.
Yeah, we'll love to actually hear your presentation. Because I always look forward to it.
So is it visible? My slides are visible?
Yes, your slides are visible. If you maximize it, Dr. Uday. And
just 2 days back, I have been asked to show something complication in my Cath lab. Fortunately or unfortunately, one complication happened basically just day before yesterday. And that is why I'm showing that cases. And thank you, Albert, for inviting me.
Thank you.
My case is 57-year male, quite a bit obese patient. Is diabetic, but controlled with only one anti-diabetic agent. He is hypertensive. Is also controlled. Had a history of exertion and chest pain for the last 3 years, recently, which has been increased. His GCG was normal. LV function was normal, and renal status was normal. His angio was done outside, which shows right coronary was dominant and without any significant plaque. LAD type 3 vessel with moderate plaque mid-mud involving the osteoproximal part of diagonal. L6, which was a good caliber with long vessels and subtotal occlusion just after proximal part. So I kept this patient for L6 CTO PCI. So I used the right groin and 6 French AVU guide Cath, and this was the lesion of LCX just after proximal first. I say no such major OM is coming out. One ramus was there, but this was the lesion. So initially I took workhorse wire with run through floppy with the micro catheter. But it's actually perforated the proximal cap a little bit and went into the mid part of his CTO segment. After that, it's not moved. So I changed to another wire. This was the fine cross micro catheter. Changed to Fielder XTA. I thought it is a tapered wire. It can cross the distal cap as well, but it's not moving at all. So I tried a lot for say 15 to 20 minutes. Tried. But that time I thought the wire is going outside the lumen, perhaps in the pericardial cavity, checked by the echo, but there is no effusion. And tip movement was not quite good. So again, I pull it back in the proximal part and try to cross it to the distal part. Still, it's not in the true lumen. It's in the, so of course, in the false lumen. So this time I also again I try to pull it back into the proximal part, or I also planning for the another wire for parallel wire technique. And as it is a tapered wire, so this time I thought it should have been changed to Gaia wire. So I changed to Gaia wire, Gaia 1. So Gaia 1, the changing I have not seen shown yet. Slightly I thought it's more of an Indian movement, but tip movement was not quite satisfactory, but still it's moving proximally, distal to the proximal lesion. This is the time I thought that I should change it to the Gaia 2 or Gaia 3 because of the I did not cross the distal cap. So this happened actually. I initially, whenever I tried to change this Gaia first to Gaia 2, this happened. Whenever I pulled it back, it was stuck into the CTO segment, particularly just proximal to the distal cap. And this happened in the radio opaque part is totally stressed out. In this part is totally crumbled up. Here is the microcatheter. I slightly remove the microcatheter, and another segment is also actually this is the total part of the radio opaque part is totally slightly stressed out, crumbled, and I was in a chaotic situation. Patient had no such symptom at that time, but again I tried to pull the whole of the system, including the guide Cath, but it was not coming out. Then I tried to engage the guide Cath, slightly engage the guide Cath, and the radio opaque part is to some extent is coming into the guide Cath. Next time here it has been shown that this is the another balloon. This was the part of when I thought the whole of the system is stuck into the CTO segment. So I need something else to put the radio opaque part or put the Gaia wire out of the system. So I used 2.75 into 14 millimeter, 15 millimeter balloon, and it inflated up to 14 atmospheric pressure at the tip of the guide Cath, and then try to pull the whole of the system out of the system, including the guide Cath, but it was not coming out. Then what to do next? Then I used another workhorse wire. This was the C1 blue wire. C1 blue wire is a passes by the side of the previous wire. Used another 2 millimeter balloon to slightly inflate the proximal segment, but it's a 2 millimeter balloon, so it's not crossing the proximal segment, and it was not dilated earlier as well. So next plan was to use something smaller balloon. By this time, when I was trying to remove this wire, I removed this balloon, but that time wire balloon along with some of the part of the previous part of the Gaia wire totally came out, and this was the total stretched out Gaia wire. The only few part of the Gaia wire inside the LCX up to the left main across the guide catheter up to the proximal segment of the guide catheter. So this was the part of the next. This was the part kept inside the coronaries. So what I did, again, I take a new wire. This was the run-through floppy wire. Another run-through floppy wire I stick inside the LCX. This I tried to cross the lesion as much as possible with the help of a small balloon, a 1 millimeter balloon. This was the balloon marker I used, and this balloon I tried because previous 2 millimeter balloon was up to that side. But I think this small balloon was crossed beyond this proximal segment into the CTO segment. So here I inflated up to say 14 millimeter. After that, I removed this balloon along with this wire. Next, I used this was the balloon, another balloon. So I used the previously used balloon, that is the 2.75 into 14 millimeter balloon, and it inflated again up to 14 to 16 millimeter. Now it's inflated. Now I'm trying to remove the whole of the guide cath into the wire. Now it's coming out. Yes, this was the done. Whole of the system is coming out, and nothing was there inside the coronaries. And whole of the heart, nothing was there, including the groin, rest of the arterial tract, everything is free from guide wire. So this was the part. After that, I did this angioplasty with another whole system, including the new guide cath, new wire, everything. I completed this procedure. I'm not showing that one. This was my case. Thanks a lot. Thanks for patience hearing.
Yeah, thank you. That was pretty scary.
A bit scary.
Okay, I'll invite Dr. Farhan Ahmed to actually give her first comments, and then we'll move on to our next expert panelist. Dr. Ahmed? Dr. Ahmed, Farhan Ahmed, if you're around. Okay, I think Jimmy can tell us a little bit about what he thought. Jimmy?
Oh, yes, sir. Actually, first of all, there was a wonderful complication in the sense, I was always thinking the microcatheter was somewhat deep inside the proximal cap. And in some views, it looked like the microcatheter itself was outside the vessel. So the thing is, I think I don't think the Fielder XTA would have only penetrated it, not the run-through wire. In the sense, the microcatheter somehow penetrated and went outside the vessel, and that started the main issue for this thing. So that's why the entire wire segment after the microcatheter seems to be out of the major wire. So it was tautly hanging in the ventricle, it seemed to me like that. Then the problem with these Gaia wires and all these things, that there are multiple wires which are coiled around these Gaia wires. So that is an issue. Once you start retrieving it back, all these things leaves open up anyway. So that uncoiling of all these multiple wires which have been coiled to make it a single wire is the issue of uncoiling of all these CTO wires. So that also had made the issue more complicated. So the thing is, I would have even thought of trying a snare anyway, if at all possible, a coronary snare to take it out. So whether that could have been issue is what I was thinking of. Maybe others can also add on, sir.
Yeah, Deepak, what about you?
Yes, sir. Very interesting case. But then what I understood from the final retrieval was he tried to take another balloon by the side of the stuck wire, and then the balloon was inflated, which means that the initial wire got released from that stuck area. Then it could be retrieved with the help of a trap balloon. That is what was done.
Yeah.
Now, how I look at it, how could I have prevented this? Jimmy has mentioned that probably be careful with the microcatheter, the caravel, whatever we use, be careful with the caravel catheter. Secondly, when we try to pull out the wire, the rotawires can happen. With rotawires also, you can have this sort of problem. And when you have a jail, when you are doing an LED D1 bifurcation, you have a jail wire, the D1, you deploy a stent in LED, and when you pull out the D1 wire, it might get stuck. So these are situations wherein it gets stuck, and you have an initial feel that it's not going to come out. At that point of time, rather than trying to pull it out with brutal force, it's always good to have an 1 millimeter balloon. It necessarily needn't be an OTW balloon. It can just be a regular 1 millimeter or a 1.25 millimeter balloon. You can go as close as possible to the wire where it's got stuck. Then push the balloon and pull out the wire. Many situations it comes out. So it has happened to me. And once I pulled it out with brutal force, it unraveled, and it was a major difficulty like what you have presented. But once you come across these sort of unraveling, then the next time we tend to be very clear that if it doesn't come out, do not pull it hard. Take a 1.25 or 1.5 millimeter balloon, go as close as possible to the stuck area, push the balloon deep in and pull out the wire.
Yeah, I think you're absolutely right. I mean, pulling a wire, particularly CPO wires, you mentioned about the number of coils, could be actually from Kashmir to Kanyakumari. You can be very sure about the length of the wire.
190 centimeters wire also become
it can easily become 800 kilometers, for all you know. So, Dr. Ghosh, your comments about using a snare against this?
I think the snare would be difficult to operate inside a coronary. One thing, when it was not crossing with the A wire, what I would straight away go to a Gaia without any microcatheter support. The Gaia operates reasonably well. You get a lot of support even without a microcatheter or a balloon. Because the moment you have a support system like a balloon or a microcatheter, you make the wire very aggressive. So if you are using in the second slot, if you had used a Gaia wire on its own and using a coated wire in a CTO is always a risk, because you don't get the feel. You don't have that feel of the wire because it's so slippery. You don't get that grittiness of a feel when you're leaving the artery. So that is something on the second step, once the wire, if I plan to use a Gaia, I would use a Gaia straight away with a Gaia 1 maybe, because the lesion was pretty straight. The artery course was not very curved or tortuous, and even without any kind of support, and maybe I would have succeeded. That's the only thing. Once you've had a complication, I think Uday did very well to retrieve that. I think this is a trial and error method. Whichever works for you has worked, and at the end of the day, if it has worked, it's done absolutely its job. And I think I have actually what Dr. Davidson said. I've had my problem with that. I had done a RCA intervention. Unfortunately, the wire was left in a very small artery, and it penetrated and it wouldn't come out, and it wouldn't. And that is one thing. What I did, I took a 1 millimeter balloon, pushed it, and it released it. So that is definitely my experience as well. I've had that, let's say, the good fortune of doing that. But I think with the Gaia wire, I think initially it is better not to go with supports. If it penetrates, it penetrates. Actually, it penetrates quite well, actually.
Deepak, any chance of leaving the wire alone? Not this big, but yeah.
Yes, sir. During my PG days, I've seen one done that way by Haridas sir. at Ames Hospital, and even 15 years down the line, he was a politician. He's doing well with a wire coming out from the circumflex artery from the left main almost till the aortic bifurcation. Even now, he's doing well.
I remember in one of my stints with Antonio Colombo in Milan, when he just left the wire it broke off, and everybody was worried as to what to do with it. This was in the late 90s and all. And so just leave the wire, it doesn't come out, it doesn't want to come out, it wants to stay there, let it be there. And he was so cool about it. So we talked about him, there's Althambas and this and Watford, and no issues. Leave it there. Those were the kind of approaches we have seen as well. So yeah, but this is, I think, wonderfully done, and such a difficult thing which came out. I was very surprised as well. But well done, Uday. So I think we'll move on to our last speaker, the dessert on the cake.
Sir, thank you so much for the opportunity given. Well, I'll start sharing the screen. So just to complement these three cases, these three presentations, over the next 10 minutes, I shall just take you through three short cases just to complement these three cases. Number one, the wire that got stuck. Just to complement that particular case, this is one patient who had a heavily calcified mid-right coronary artery stenosis. We started with through the femoral approach with a 7 French short Amplatz left guide catheter with a temporary pacemaker in the right ventricle. We tried to open up that mid-right coronary artery. It was a failed angioplasty elsewhere, so our plan was to straight away go ahead with rotablation. We wired with a workhorse wire, that was the Versaturn wire from Abbott. We tried to get a microcatheter across. It was difficult for us to get the microcatheter across that angle of the right coronary artery. So we had to ultimately leave the microcatheter there, take out the Versaturn wire, and try to wire with a rotafloppy. So you could see that with difficulty we were able to get the rotafloppy across that particular bad angle, and slowly we were able to get the rotafloppy into the distal right coronary artery. And then we started off with a 1.5 millimeter burr. You could see that it was difficult for us. It took quite a long time for us to get across that angle. And you could see that meanwhile, as we were trying to do the burring, the wire started coming out. Many times what happens is, as the burr doesn't cross, you tend to become impatient and you try to push the burr across. At that point of time, what happens is the guide catheter backs out a little bit and the rotafloppy also comes back. So you could see here that the rotafloppy is coming out as I'm doing the burring, as I was trying to push. So one way of getting the wire distally into the vessel is, as you keep burring the lesion, the second operator can press the brake defeat and push the wire distally. So that is what was done. You could see here in the first image that as I keep burring, the second operator, somebody who is standing by the side, can push the brake defeat and then press the brake defeat and push the wire distally. So you could see here that the rotafloppy is going distally inside the vessel. So we were happy that the rotafloppy has gone distally. Now, once we were done with the rotablation, we wanted to dilate it. So while dilatation, we always leave the rotafloppy there. You could see here that in the first image, the rotafloppy is inside a small twig. It is bent and it is sitting inside a small branch. So we kept the rotafloppy there, took a workhorse wire, that's a Versaturn wire, went ahead with a balloon and tried to dilate it. So that was the balloon dilatation being done. And once the balloon dilatation is done, before we pull out, take the stent in, we always try to take the rotafloppy out, because the rotafloppy can get stuck to the stented segment, because the distal radiopaque part is much bigger than the proximal portion of the wire. So we wanted to take it out. So that's following the balloon dilatation. In the second image, you could see that the rotafloppy is inside the PDA. It's inside a very small branch, hardly 2 millimeters inside that particular vessel. Now, next thing what happened is, as we are trying to take out the rotafloppy, it wouldn't come out. So that is what is happening there. It's just sitting there. It wouldn't come out. So what we try to do is, we try to give gentle traction. Still, it wouldn't come out. So next thing what we did was, you could see here in the first image that I was taking a 1 millimeter balloon over the rotafloppy. You could see that it's going over the rotafloppy. And once it reached the stuck area, I was easily able to take out the rotafloppy. So you could see here that again, I'll show you the balloon is going there. It reaches the distal segment, the distal part of the rotafloppy, and just we were able to take it out. And finally, we were able to get the stent across. That's then, in spite of we were anticipating difficulty to get the stent across that bifurcation. That was then expedition stent with the help of a guide plus catheter. We were able to go across, deploy it, and we were able to achieve a good result. That is just to complement the last case. If you feel that the balloon is the wire is stuck, do not pull it out. Try to get a balloon closer to the stuck area and then pull it out. This particular case is just to complement the one that was presented by Dr. Jimmy. This elderly lady, she had a proximal LED critical lesion. That was a 6 French guide catheter radial approach. We were able to dilate it and get the stent across. It was a 38 millimeter expedition, positioned right at the ostium of the left anterior descending artery. We also had a wire inside the circumflex artery to make sure that we were positioning it right at the ostium. The stent was deployed. Once the stent was deployed, we could achieve a perfect flow inside the LED. But however, it was a long stent. We had to go ahead and post dilate it. So that's the post dilatation being done in the first image. And second image was something very interesting. You could see that following the post dilatation, you could see that there is a haziness at the left main bifurcation. You cannot just stop the procedure there. The flow in all the vessels are good, but still looking at that particular haziness there at the left main bifurcation, you cannot stop the procedure there. And so we had to do a start off with an imaging. So that is the point that I wanted to highlight. When you have a left main dissection, you have a mental resistance in starting off with an OCT because the hydraulic pressure, you might, if it's a dissection, you might further propagate the dissection. So always, as I do, I start off with an IVUS imaging. With IVUS imaging, I was in no way wiser. I couldn't understand what exactly was happening there. Was that a distal dissection at the left main? No information could be achieved with the help of IVUS imaging. So went ahead with an OCT imaging. That's the OCT pullback from the LED back into the left main. You could see here that the stent is positioned right at the ostium of the LED. It was positioned exactly right at the ostium. And what was interesting beyond that is you could see here that that's the ostial LED stent. You could see here that there is a small intramural hematoma over there. That's the intramural hematoma. You could see in the next movies that this particular hematoma, it's actually seeping back into the left main till almost this particular area. So that can be highlighted in this particular image. You could see here, if you follow the cross section, inside the stented segment, you can see that there is a dissection there. There is an intramural hematoma. That's the intramural hematoma 5 o'clock position. That's again the LED. It is seeping back into the left main. You could see that circumflex ostium. So this has come into the left main, hardly 2 or 3 millimeters back into the left main. You can again see that particular image once again as it runs. So that's actually the intramural hematoma. Okay, again, you can see that this is a stented segment LED. You can see that there is a dissection inside the stented segment. There is the hematoma tracking into the media adventitial area. And as we are coming back into the left main, we are almost at the left main. You could still see that hematoma is there. That's the hematoma. Further, we are inside the stent is not seen now. Now this is the left main. You could see the hematoma sitting there. So we understood that this was a hematoma that was initiated inside the stented segment. It came all the way back into the left main, and that was the reason for that particular stain. Now this is how we went back and evaluated. We went back and saw all the images, and we understood that in the first image, you could see here that during the post-dilatation, we had a pinhole rupture of the balloon that was positioned at the ostial LED. So what happened was, because of this pinhole rupture, it dissected the contrast. It dissected into the stented segment and went back into the left main. So that was exactly the reason, which was clearly identified with OCT, which could not be identified with the help of IVUS evaluation. So we understood that it is not a dissection inside the left main. The origin of the dissection is inside the left anterior descending artery, and the contrast, it came back into the left main. We waited for almost 20 minutes in the cath lab, and later on we identified that that particular stain was not persisting there, so we stopped the procedure. So this is just to highlight the usefulness of OCT over IVUS in these sort of challenging situations. And that's my third case. Just to complement that DK bifurcation case, this is an LED D1 bifurcation. Sir, can I finish it off within 5 minutes?
Yes, yes, absolutely,
yes,
absolutely.
Yes. So this is an LED D1 bifurcation. It's a complex bifurcation. Why do I call it complex bifurcation? Because it's more than 90% in the side branch, and it's more than 10 millimeters in length in the side branch. So because the lesion is more than 90%, more than 10 millimeter in the side branch, it's a complex bifurcation. And so we decided on a 2-stent strategy. We started off by preparing both the vessels, and both the vessels were prepared. We did an OCT run, and we made out that it was almost a narrow bifurcation. You could see in the OCT image down there that the carinal angle is very narrow. When you have a very narrow carinal angle, less than 50 degrees, you are likely to occlude the side branch if you go ahead with a crossover stenting across the diagonal branch. So based on all these findings, we decided that we'll go with a 2-stent strategy. We decided on a DK crush strategy. So we went ahead, we prepared both the vessels and deployed a stent in the side branch. That's a long stent, the long expedition in the side branch. So that's a positioning of the stent being done, and the stent was deployed in the side branch. Once the stent was deployed, we pulled it back a millimeter. We pulled back the balloon from the stented segment a millimeter and further dilated it at 16 to 18 atmospheres. Now, once this is done, the next step, what we routinely do is we take out this balloon from the side branch, take out the wire from the side branch, and crush the stent that is positioned in the side branch. So that is the next step. Now we have a modification by Francisco Lavara. You could do something known as proximal side optimization. That is how the cartoons look like. When you normally position a stent in the diagonal branch, you design the stent. The size of the stent is based on the distalmost size of the vessel. So let's say I took a 2.5 millimeter stent for this particular side branch. The distal side branch is 2.5, and proximally at the ostium, probably it might be 2.75 or a 3 millimeter vessel. So when you deploy a stent like this, and when you crush it with a balloon, what could happen is you crush it something like this, and you have a small gap over here. And when you want to recross into the side branch, the space for optimal wiring into the side branch would be something like this, almost 50% of the ostium of the side branch. So you cannot go through the most distal portion. You cannot go through this particular area. The space for optimal wiring would be significantly less. So what he has suggested is you can do a proximal side branch optimization. How would you do a proximal side branch optimization? After stenting the side branch,
yourself. Yeah, carry on.
Yes. After stenting the side branch, remove the stent balloon from the side branch. Before crushing it, you could take another balloon which is sized 0.25 to 0.5 millimeter bigger than the stent size, so that the ostium can be further very well flared in the side branch. So this particular balloon, as you see here, it flares the ostium of the side branch. Then remove the balloon and the wire from the side branch, and then crush it. The advantage is you could have a better space for optimal wiring into the side branch. So you have multiple cells through which you can recross into the side branch. So that is the idea of doing this sort of proximal side optimization, that is known as PSO. So proximal side optimization. So that's what we did. We removed the balloon from the side branch. We took a new balloon into the side branch, which was sized 0.25 millimeter, more than the stent, that is a 2.75 millimeter balloon. You could see the balloon going into the side branch. That further optimization of the side branch ostium was done. Once the optimization was done, we slowly pulled the balloon in the LED and crushed the stent. That is the first crush was done. Then we took a much bigger balloon, which was optimized for the proximal vessel size. The second crush was done. Following first and 2-step crush was done, and then we recrossed into the side branch. Now, one challenge that happened so here you could see that when we recrossed into the side branch and when we did an OCT run, you could see in the lower OCT frame that there are multiple cells sitting at the ostium of the side branch. So you have multiple options. You have a proximal cell, you have a middle cell, you have a distal cell. You could so the advantage of doing a proximal side optimization is you optimize the side branch ostium, and when you crush it, you have a huge multiple number of cells through which you can decide whether you should be going more distally, you should be going more proximally, or through the more middle cell. So here we identified that the wire has gone through the middle cell into the side branch, which is again confirmed with the 3D bifurcation mode. First kissing balloon dilatation was done. Then the second stent was deployed inside the LED. Pot was done. After pot, we recrossed into the side branch. While recrossing into the side branch, you could see the wire looping there and then into the side branch. Now, if you look at the second image, what was happening there was we recrossed into the side branch, but then none of the balloons would go into the side branch. So we were in dire straits. The balloons were not going into the side branch. That's a 1 millimeter balloon. Even that wouldn't go into the side branch. So again, we went ahead with imaging. So wanted to see, we were not sure what was happening, why the balloon was not going into the side branch. When we did imaging, we could identify that if you look at the side branch ostium, the wire has gone through a very distal cell into the side branch ostium. So we would probably want to have the wire going through a much proximal cell into the side branch, but this wire has gone through the more distal cell into the side branch, and we were more wiser looking at the bifurcation 3D mode. If you look at this bifurcation 3D mode, you could see here that there are huge cells sitting at the proximal portion of the side branch. Here you could see that there are big cells sitting over there, but then the wire has gone through a very eccentric, very distal, very remote cell into the side branch. And that was the reason why the balloons were not going into the side branch. So imaging made us much more wiser. So at that point of time, we pulled out the balloon, pulled out the wire, and went through a distal cell. That is a fluoro save. You could see that we took out the balloon, took out the wire from the side branch. We were trying to recross into the side branch. Once we recross into the side branch, you could see that in the same frame itself, the balloon could be easily negotiated into the side branch. As you see the follow through of that particular image, you could see that the balloon which is coming from the left main, it is easily gone into the side branch. So this is just to highlight the fact that imaging made us more wiser. We didn't understand why the balloons were not going into the side branch. Based on imaging, we understood that the wire has gone through an eccentric cell. That was the reason why we were not able to negotiate the balloon. Then went ahead with the second kissing balloon dilatation proximal optimization, and that was the final result that we could achieve. Thank you, sir, once again for the opportunity given. Within short period of time, I was able to fish out these 3 short cases which are complementary to the cases that were presented. Thank you once again.
I think, Deepak, from next time onwards, we're going to do this to you. When you finish up all the presentations, and then you can summarize it with your 3 presentations rather than talking on something. This is a wonderful case. I think the last one you showed. I just wanted to know, do you do routinely OCT to see in exactly what kind of position the wire has gone, or is it when you get stuck that you do it?
So many times if we decide on imaging to the bifurcation, we start with an initial OCT run just to see the bifurcation angle, to see the BPCT length and the vessel sizes. Then the second run after crossing into the side branch, just to see whether it was a crossing through the proximal or a middle cell before getting the balloon across. Then the third OCT run following the second stent deployment, recrossing into the side branch just to see the position. And finally, so we usually try to take four images. So in this sort of difficult bifurcation, we always make it a point that we take a New York OCT catheter, because you need to push in multiple times, because if you go with an Oxford OCT catheter, it's extremely difficult. I hope, Jimmy, that's your feeling also.
Second, right? OCT, do you usually do it to check exactly what kind of cell you are in?
Yes, sir. We try to do that when it's left main bifurcation, but when it's an LED one, we try to avoid it. But then here it was a difficult situation wherein the balloon was not going, so we decided to image it once again.
Jimmy, what about you?
Exactly, sir. The sense like what Deepak sir was saying, anyway, nice cases in that sense, but imaging like every time, if at all you crosses out, if you have a doubt whether you're crossing distally or intermediate or you're crossing proximally, it's not that you don't need to inject a large amount of dye. You just need a 10 ml only to inject and see only the carina part, because we just need to see whether the crossing is right, whether we need to see the struts have opened up or whether the joining point has opened up or not. So there is a small shoot. I don't even say like maybe sir 8 to 10 ml would be enough to get a good shoot over there to see out, because you don't need the entire stent part for the deployed out there. So definitely 3 to 4 shoots is very much required if the creatinine values are okay also. Even like when the creatinine is slightly on the prolonged rate also, the first shoot would be a better one, and the rest all shoots you can just make it in the 20 ml or 25 ml and finish it off all the 3 shoots. A nice case of Deepak sir. The first case was a good educative case, really shown the metal that how even if your stent, even if your rotor wire gets stuck anyway, got methods to get the wire out anyway. I was thinking that you were passing a microcatheter and trying to pull it out anyway, but it was a 1 mm balloon. That was a nice teaching what you have shown out anyway. And the second case, like OCT has really scored, like it's almost like what I'm saying, they've got a dissected flap over there. And if the OCT had not been done, I think you would have gone with the LM crossover stenting. And again, opening the structure of the circumflex would have made it more difficult, or maybe a result would have been a difficult one with more metals over the left main or distal left main. And the last case, I thought like the vessels were equal size. Maybe you will be going for a culotte and most probably a DK culotte, but you ended up in a DK crush anyway. But few things what I learned also was the proximal different NC balloon of 0.25 to 0.5 size, which is to open it up so that the second crossing would be easier to the intermediate or maybe the proximal. So that was quite educative and quite nice cases.
Thank you, Jimmy.
Thank you, sir.
I think as we move on from Singapore to the European side, the DK crush also moves from Singapore to the culotte thing in Europe. So it's the kind of thing. And the second thing, I think, we are blessed in our institute with the nephrologists who never bother, when we tell them for a renal clearance for high creatinine, they just tell you, go ahead, we'll look after him. That's why we're here for, if you had normal creatinine all the time, what will we do? So, I mean, that is one topic I think we can always discuss some other time.
Sir, I had a small question to the box here, sir.
Yes, please.
Sir, in the second case, there you showed that in OCT, it's hematoma. Suppose this type of things, if happens in the proximal edge or distal edge, when close to the stent start, either ending or proximal part or distal part. So how do you differentiate whether it is hematoma or edge dissection?
Here you were very clear that from the stented segment you're able to see the entry point also. So you could clearly see that the entry point was there. There was a dissection inside the stented segment, and the hematoma was sweeping back into the left main. But it's not a proximal or a distal edge dissection, because you are clearly seeing the end of the stent. The proximal end of the stent was very clearly seen, and there was no dissection there. So we were sure that it was something that was happening inside the stent, and the hematoma went into the media adventitial area, and then it came back into the left main.
Thank you. We'll give Dr. Devashish Bose the honor of concluding the sessions with his expert comments. Over to you, Dr. Bose.
No, I think it was absolutely, there's nothing much to comment. I think it's been discussed extensively, and Dr. Davidson's cases were very teaching. I also learned this new proximal optimization with a second balloon on the side stent. One of the reasons why basically why the as you said, Singapore and eastward is more with the DK crush, and the Europeans do the other way. That is because you have to understand the superiority of the DK crush trial. You see the operators who were doing it. The operators who were doing it had 300 plus angioplasty with minimum 25 left main stem angioplasty. Now, that kind of experiences will produce that result. And that is important to understand, that you have to have the limitation of your system in place, and when you venture out with a DK crush. So that you need to have experience with the DK crush. It's a better technique, no doubt, but it's a much more demanding technique. And I think, on the other hand, if you go to a more simpler provisional strategy or whatever, the culotte, it's significantly easier. So you must understand your let us say the capability of your setup. That is very, very important. If you see the,
and also the philosophy of life, I mean, Europeans stop their work on Fridays.
And also their arteries are much more bigger.
Much bigger, yes, absolutely. And we are in the middle. I think we are very well placed in India. We have very good operators of Crash, excellent operators who actually also do culottes very well. So that's very well done. So I think this was a wonderful session. Dr. Devashish Ghosh, Dr. Jimmy George, Dr. Deepak Davidson, and our guests from Bangladesh, Dr. Farhan Ahmed. A wonderful case by Dr. Uday Shankar, and also by Dr. Pathak. So I think we'll finish this session. That we had a lot of learnings in this 1.5 hour session, and hopefully we'll see you again sometime later. So good evening, everybody, and have a good weekend. Thank you.
Okay.